speaker mode. Okay, can you see that okay? All right.
Yes.
Um, I don't know if you guys have you guys had talks on FASD already?
Not recently.
Okay. All right. I just want to see what you guys know or don't know already. But I just wanted to share this is our team. So we started this clinic in 2010. Dr. Tangent is our neuropsychologist, and she and I work really closely together with this clinic. And we did training and with people from Washington, University of Washington, to kind of see what we should do. And it's just really grown and blossomed. And the other people in this picture are Dr. Kim Burkhardt. She's a psychologist we work with, and she's just phenomenal. I'll talk a little bit more about what we're doing at the end with her. Or not Dr. Jewel McKinley is our social worker, and she helps to connect patients with resources and things. And then a really important part of our team is Jennifer Gowleck, who helps to coordinate. She's our nurse who helps coordinate the clinic. So she gets um, names that come in. She does triage calls with them and make sure we have all the information that we need for our clinic. Um, all right, so I have about a half an hour worth of slides. I hope if we have time for all of that, that'll be good. I will talk kind of fast because there is a lot I want to get through. So I learned recently that residents listen and medical students listen to things on 1.5 speed when they're when they're listening to get through. So I feel like I'm going to talk at 1.5 speed. Um, but so I want to just go through this. Why is knowing about this important? And it really alcohol even more than drugs, and we see drug exposed kiddos too. Um, our whole our whole like program is the RISE program now, Rainbow Interdisciplinary Substance Exposure. But of all of them, alcohol causes more damage than the others. And it's really, really common. Um, Drinking alcohol is very common, but also because of that, it's the most common developmental disorder that we see. It is about 1 in 20 estimates of kids who have some sort of alcohol-related disorder, and it's under-identified um, around the world. And it's 100% preventable. Um, we still see the studies actually show that when the alcohol bottles were labeled in about 1989, they were hoping that pregnant moms would stop drinking during pregnancy, and the rates have not decreased really at all. And arguably during the pandemic, they may have increased again. We're waiting to see those numbers. But it's even labeling bottles. But parents are aware, moms are aware because they will deny drinking alcohol during pregnancy, but they will admit to using drugs. So they know it's not great to do. So what happens when a mother drinks alcohol during pregnancy? Basically, the alcohol gets into the placenta freely. It's through the bloodstream. Alcohol's in the blood. It gets from the mother's blood to the baby's blood very easily. And then the baby does not have the liver enzymes to break it down yet. The alcohol dehydrogenase just doesn't work. The liver's just not formed yet. It's not working fully until well after delivery, even. And so the baby can't break it down with the enzyme. It has to break down naturally. So they end up going through their bloodstream, they pee it out, and then they're swimming in it in the amniotic fluid. And then they drink it. And the cycle just keeps going until the alcohol breaks down naturally. So, and a lot of how much affects the baby depends how much the mother is drinking. It also depends on the baby's genetics. Our genetics do vary. There's actually a mouse model that's resistant to the effects of alcohol. So we see such variability in these kids who have exposure. They do consider heavy drinking more than 7 drinks a week and a binge drink, which is more harmful. It's all harmful, but more harmful to have binge drinking, which is 3 or more drinks per week. In women, it's different in men, but in women is what we're thinking about. And so much depends on the timing when a mother is drinking during pregnancy. So oftentimes it's the first trimester before she finds out she's pregnant. And the first, if you look at the numbers at the top, between that 9 and 16 is that end of the first trimester. And that's when all the organs are formed in the body. So depending on when she was drinking in that first trimester, if it's the week the heart was formed, you might see a heart defect, or the kidneys, a kidney defect. And the face is formed. We're going to talk about facial features in a bit. The face is formed during the about the ninth week. And so you tend to see underdevelopment of the mid face during if mom was drinking that week, but really she could be drinking the rest of the pregnancy and you won't see many facial features. And that's unfortunately makes it hard to identify. Um, and then we think about the brain. The brain is forming the entire pregnancy. And in that first trimester is when neurons are developing and multiplying. In the second trimester, they're migrating to where they need to be for their function in the brain for the body. And then in the third trimester is when a lot of the synapses are all kind of getting elaborate. The dendrites are forming, and myelination starts. And myelination continues, I think, till about age 25 years old. But it really is big during that third trimester and the first 3 years of life for a child. And these things at the bottom, by the way, I'm going to go into a little bit of that later, but this it kind of gives you an idea of what might be affected in the child's brain and body, what functions. So what is FASD? It is basically fetal alcohol spectrum disorders is an umbrella term. And it's the term itself we don't use for diagnosis, although I wonder whether that might change in the future because it's getting really blurry. But the terms we use under the umbrella term are fetal alcohol syndrome, partial fetal alcohol syndrome, although that's getting controversial as well because partial is still fetal alcohol syndrome. Um, and then there's alcohol-related neurodevelopmental disorder. And then there's this one at the very bottom that we are using that's in the DSM, and I'll talk about that shortly. The neurobehavioral disorder associated with prenatal alcohol exposure. Um, but while we often make the diagnostic system really seem really complicated, it's actually quite easy. And all of you as clinicians, I missed the introductions. We have st medical students here? Is that right? Yes. I can't see anybody. Sorry. Um, but if we have trainees, I believe, in the room. Okay. Um, so if you have exposure to alcohol confirmed and at least some dysfunction with your brain, meaning like a behavioral disorder, delayed development, or learning disorders as kids get older, then you have, by definition, you have a fetal alcohol spectrum disorder. And then it's a matter of deciding which one. Um, but that bottom one on that slide before, neurobehavioral disorder associated, or it can also be called neurodevelopmental disorder with prenatal exposure, is a nice, just descriptive term. And you can give that disorder if you have confirmed exposure and some dysfunction. Now, by the time I see kids in developmental pediatrics, they definitely have dysfunction. That's why they're coming to see me. So that's sort of their gateway into being evaluated is having an issue. And then I always ask every patient if they've had exposure. And I think so, yeah, I ask the parent is I think it's really there's actually some information on the AEP website about kind of how to ask parents. It's just easy to sort of say, when did you, and I tell them, I ask everybody this, when did you find out you were pregnant? And then they tell me, I'll say, well, did you drink any alcohol, use any medications, use any drugs, smoke cigarettes before you knew you were pregnant? And most of the time they say no, or sometimes they say yes, if it's just in my general clinic. But if they're coming to this specialty clinic, then most of them have had at least suspicion of exposure, if or exposure. Many times I'm not seeing the birth mother by the time they get to me. They're in adoptive homes or in foster care. So, all right. So when should you consider an FASD diagnosis? Anytime you have developmental, cognitive, or behavioral concerns, you should make sure to ask those questions. If there's history of alcohol or drug use, because they go together, a lot of times moms are using drugs and they're usually at least sometimes drinking alcohol as well.
All right, see you soon.
Did someone say something? Oh, someone's not muted, I think. Um, so, yeah, and if there's a sibling who has an FASD, like if you're in an adoptive home and they know that previous siblings had exposure, I would have high suspicion. The rates are very high in adoption settings and in foster care settings of fetal alcohol exposure. If you have complex medical, like heart defects, any kind of physical issues, you want to think about genetics, getting genetics testing. Any dysmorphic facial features should also be seen by genetics. But one of the things they also look for is fetal alcohol. So to consider that. And if you have a child who's really, really small, I had one patient who was really small at adoption, cute kid, looked great. Parents adopted him from Russia and everything was kind of okay. They put on their paperwork they did not want a fetal alcohol syndrome kid. They came back to see me down the road and said he's just not growing. He's got these major behavior issues, major ADHD, and I did his facial features and he was small and he met criteria for fetal alcohol syndrome. And he was really a great kid, but the mom's face just went white. She was just devastated to hear this. And, they didn't come back. And I was hoping they would because they need, you need to be guided through. These are great kids, just like autism kids are great kids. You just have to understand where they're coming from and parent them from that perspective. I have to have a sip of my tea here. I think my voice box doesn't work this much this early often. So the main criteria that all the systems use, and I'm not going to go through all the different criteria systems today, because there are small differences and in developmental behavioral peds in our national uh, association, Society for Developmental Behavioral Pediatrics. We're actually talking about how to standardize the criteria a bit and make it easier. So, but the main criteria everyone uses is there alcohol use or not? And do they have some signs of neurodevelopmental abnormalities? Those are the main two, like I said in that other slide. And then we also look at the physical findings. If you have physical findings, it can be helpful to confirm the diagnosis or the severity of the diagnosis. But if you don't, it's okay. You still could have a diagnosis. But as if you're going to pediatrics, and you are going to see these kids. It's like 1 in 20 kids are going to have some sort of an issue. So it's learning how to identify them and understanding the physical findings is part of that. The brain, I think, is the most important part. I maybe am biased on that, but because it's my area of specialty. But I really think that it's so important that we understand how a brain is functioning in a child so that we can help teach them, parent them, and help them reach their potential, help realize their vulnerabilities, because as they grow up, they do have vulnerabilities. And so here's a list of things that like Dr. Tangent will test for on the neuropsychological evaluation when we see these kids. You don't have to have all that testing to make a diagnosis. You can look at just what you have, developmental delays, or if they're school age and struggling with learning, they can get a learning evaluation at school, and you can use those results as well. But these are the areas that can cause difficulties from intelligences like IQ, memory, verbal memory, visual memories, language disorders. And it's not necessarily how they talk, but they do sometimes have like articulation difficulties, but it also includes in language how they express themselves. And a lot of these kids have social communication difficulties, and that can affect how they understand things and express themselves. Attention issues are huge. I always say these kids their brain is uninhibited. And that's a big part of their executive function and attention and like impulsivity. Their brain can't say stop. Those higher level pathways are underdeveloped. Because when the brain is like drunk during in utero, like those cells stop growing. And that's how you see all these birth defects and things. The cells just stop or slow down. So you get a very disrupted brain development in a lot of these kids if mom was drinking through the whole pregnancy. Um, Visual spatial deficits, fine motor issues. Adaptive functioning means like for communication, for example, not so much um, can you talk and communicate? It's how well do you do it? And things like how well do you do your daily living skills at home? Like for a young child, it might be how well can they dress themselves? Can they manage feeding and things like that? And then socialization is part of adaptive functioning. How well do they socialize with others, but also their social emotional skills are really delayed in these kids. But there's no real specific, like definitely you're going to see these. It's so variable depending on when a mom drinks, which makes it really hard to say, if you see this, it's FASD. So these things, this is that sort of adaptive functioning and the things that we tend to see. This is the criteria that's in the DSM-5 for fetal alcohol spectrum disorder. And they call it the DSM-5, they don't look at physical findings at all. They're just looking at brain function and exposure to alcohol. So, but these are again the main three core areas that they look at, and it's not hard for you as clinicians to be able to identify, oh, they're having learning issues, they're not functioning well. And this ADHD picture, the uninhibited brain. And the uninhibited brain can apply to ADHD symptoms, but also social emotional symptoms. So these kids tend to just get upset really fast at small things, really frustrated easily. And then, as I mentioned, the adaptive functioning. So when should we be thinking about this? From during pregnancy, of course, but when these kids are born, it's really important to look at some of the issues they might have. You might see the facial features at birth if it's very severe, but you might not. They're most prominent during the toddler and preschool years, like the 2, 3-year-old range, but they're there their whole life. That doesn't go away. It's just you're not always thinking about it, but it's really more easy to see as the mid phase starts to develop more during the toddler preschool years, you start to notice it. But you might have really irritable baby. They might be floppier, like have delays in their skills. They might be in their motor skills, like rolling over, sitting and walking. But some of these kids, to be honest, have high tone also. So that's not necessarily low. And some of these kids with high tone, and they're so busy and active that they're walking early. But they're super active and getting into things that they shouldn't. And poor suck is a common sign. If you see a baby with a poor suck, it should be looked into. It's not common for a kid to have a weak suck and not be able to process that. Suck swallow should be there from birth. So if that's an issue, we often ask that years down the road when I see these kids, how did they feed when they were a baby? And then toddler to preschool, these are these kids who are super active and impulsive. They have a lot of temper tantrums. They don't always follow instructions. You'll see in a typical kid, you'll see that by age 1 to 1.5, they understand that word no already. And they'll look at you say no, and they'll look at you and they might do it anyway, but these kids just go. They don't understand. They don't learn from consequences easily. And so you start to see that really early. And then delays in development as well. Kindergarten to 6th grade is a really crucial age for helping these kids. Not only, I mean, learning and socializing are just so important. So I always say it's really important to help a child grow up to be happy. That's the number one most important thing, that they grow up to be happy. And if they're struggling as a child because they're getting in trouble all the time, they're struggling to make friends, they're not doing well in school, it's really, and they don't understand that consequence of like, going up to kids and and being too much in their face. They're very social. Kids with fetal alcohol are very social. They just don't know how to do it well. So kids after a while tend to like push them away and not want to play with them. And um, the other thing that happens is they're really, really gullible. They want to make friends and they don't understand consequences. They don't understand how their behavior affects others. And I'm saying they generally, this is not all kids, but these are the things we tend to see. I think by the time they get to me, this is what I'm hearing about. There's plenty of kids that don't make it to awareness for their fetal alcohol exposure because their issues aren't that bad. So, but these kids don't understand consequences. And so I ask parents, are they just doing the same? Like they're jumping off the table over, even though you've said no, even though they've gotten hurt, they continue to do that kind of behavior. And parents are like, yes, exactly. And I can give them a timeout and I can take away their electronics time and they still do it. What we say is they know the rules and they will tell you, yeah, I'm not supposed to do this or that, but they can't follow them because their brain can't say stop. And that's one of their biggest problems as they get older. And so they end up getting in trouble and trouble and trouble. We want hopefully for them to learn these things as they grow up because I've had patients like steal cell phones at school or steal someone's snack at school just because they wanted it or do something. And they say, and you ask them about, the parent says, then they lie about it. And you ask the child, why did you do that? And then like not tell the truth about it. And they said, I just didn't want to get in trouble. Because their biggest motivation is they don't want to get in trouble. Not that they understand stealing someone's snack or phone hurts that other person. They just don't want to get in trouble. So it's really hard teaching these kids. So I tell parents lots of repetition. You just have to say it over and over again. And they also separating fantasy from reality can be a big one as well. I find this in kids with autism also. We're starting to compare the social skills between kids with autism and the kids with fetal alcohol. And it's just as bad with fetal alcohol. But the difference is it's that the autism kids have a social disconnect, whereas the kids with fetal alcohol really want to socialize. They're not like not looking at you. They're connecting, but they don't know how. So they eventually, kids just, like I said, don't want to play with them. But separating fantasy from reality kind of happens usually by age 5, 6 years old, for sure. And these kids might take longer to do that. A sip of my water. So what we talk a lot with parents about, by the time they come to me, they are school age usually. So I welcome earlier kids. Like bring me those toddlers so I can educate those parents. A reframing needs to happen. These kids are framed as the left side here, stupid, disorganized, they're troublemakers, they're defiant, oppositional and defiant. I get all the time. I don't give that disorder because I feel like kids are oppositional and defiant for other reasons, not because they want to be. They just like don't want to get in trouble. They don't want to do something at school because it's hard and they don't want to feel like a failure. Anxiety is a big culprit as well. And they're liars. And like parents will say that to me and I'll sort of reframe that. So they take things and then they don't tell the truth about it because they don't want to get in trouble instead of stealing and lying, which we hear that all the time. And so the right side of this, the right column is really how we have to help reframe this. They really don't get it. And I had a parent recently saying they're making really bad choices. They just don't want to do this. They're choosing to do the wrong thing. And I said, it's not that they're choosing, they just can't. They can, like I said, they can tell you the rules, they know what they should do, but they just can't follow it. I have a 16-year-old patient right now. I'm struggling with this. Because he's smoking marijuana and vaping marijuana in the school bathroom and at home, even though he's had major consequences for this, major. And all the other kids who taught him to do this ran and got away, but he's not, he has executive function deficits. He's getting caught because he doesn't understand. And his reasoning for doing it is because he feels better. Now that he's done it, now that he's been introduced to it, it calms him down. And so that's what he says. I do it because it calms me down, but I don't want to tell anybody because I'm going to get in trouble. But he gets in trouble anyway. So, all right. So basically, yeah, it's sort of a reframing. It's important to know there's a lot of comorbid disorders that go along with FASD. It's not just that. It's that the fetal alcohol diagnosis, whether it's alcohol-related neurodevelopmental or neurobehavioral with exposure or full FAS, comes with all these different diagnoses. So I tell parents it's still an umbrella term. Neurobehavioral disorder or neurodevelopmental is still an umbrella term. It's what are we treating under that? And ADHD is the most common thing that we see along with learning disorders. If they've had a lot of alcohol exposure, they will have a lower IQ. So there's that's sort of that lower IQ kind of kid. And those kids get identified quicker than kids who just have ADHD. Because they're in the system where they're in school, they've got their developmental therapies going. They've been in early intervention, like our Ohio Help Me Grow or Bright Beginnings program. They get then referred into the school system with the IEP. So those kids with lower functioning actually have been shown to do better, who have fetal alcohol, than kids who are higher functioning who don't have a low IQ because they're not identified and they're labeled as bad kids. So like this conduct disorder, I actually don't like that name either. I've actually never given conduct disorder as a diagnosis. I'm still trying to like identify the other issues going on with them, like the ADHD, the anxiety, and mood disorders. So, as kids get older, alcohol and drug dependence does become an issue. I talk to parents about it's important to treat. If you have ADHD in these kids, they're not functional because of that. They get the disorder. If they can't be managed with behavioral or environmental strategies, then medication is indicated. And that's the most common medication that we use with these kids. Sleep disorders are really common as well, because if you think about that brain that can't say stop, it also can't stop at bedtime. So these kids are hyper all day and they don't feel that sort of overwhelm. Like when they get excited, they get more excited to the point of a breakdown instead of the typical kid or us who'd be like, okay, I need a break. I got to sit down. They don't do that. And so at bedtime, their brain is just total chaos and they can't bring it down to fall asleep. So we see a lot of sleep disorders. We also think alcohol probably affects that part of the brainstem that regulates sleep. So it's multifactorial. Okay, and the mental health disorders are huge, partly because their life is hard and they're getting in trouble all the time. They can get depressed really easily. First, anxiety always comes first, and then depression. So depression is a disorder of like, my life's not working. I feel hopeless about this. But we also know that these disorders are highly inheritable. And so, parents, a mother who can't stop herself from drinking or using drugs during pregnancy is depressed, has mental health issues. And so we see these inheritable things just go down the generations as well. Mood disorders, I will diagnose mood disorders often in kids. They're typically happening in kids whose mother or father has had something like bipolar or other mood disorders. And anxiety is highly inheritable. So are learning disabilities. So is ADHD. All of this is inheritable stuff. So when I tell parents at the end of the visit, I say, it's not just alcohol, it's one piece of this puzzle, but they may have inherited it from their parents. They may have also had very severe trauma or neglect. And I see that in these kids a lot. Their first few months to years of life. If they were with their birth family and birth mom still couldn't stop her drug use, drinking, domestic violence is very big because the father's around too. I've had kids come from where they're just using drugs in the home. They're the home where people come. So these kids are often neglected. So like I said, by the time I see them, they're usually in foster care and adoptive homes where these adoptive parents want they want to know, is this the diagnosis so that we can understand this child from this perspective. I'm trying to keep track of the time here. Okay, we're close to half an hour now. And the other important thing is these kids grow up, and helping them as a child really helps them do better as an adult. And I try and help teach parents to teach their children to understand themselves. We all want to understand why we are the way that we are. None of us are perfect. We all have strengths and we all have weaknesses. And I tell all my patients that. Even I, I have weaknesses too. We all do. Our parents do, all kids. And so helping kids own it as they grow up. And I heard an adult with FAS talk once, and he said, I tell my employer that I have this issue. I have a hard time remembering things. I need reminders. Could you write down my instructions of what I should do every day so I have it in front of me because I really want to keep this job. And so it's good to own it. But we tend to see higher rates of all these things in the pictures here, mental illness, getting involved with the law, the legal system. Electronics addiction is that top right one. These kids can't say stop, so they also can't stop their addiction to the cell phones. A lot of us normal people can't stop either. It's really it's really hard in this day and age. Our world has changed since phones came in, which was around 2008, I think, and it's a huge problem with our patients. But these kids, they just can't stop. So, and they get obsessed about other things too, like pornography. And I have a number of patients who so sexual health is really important. Don't neglect talking to teenagers about this. And I tell parents, just say they need to hear things. This repetition, like a young kid as an adolescent, they also need to hear, don't have sex, don't have sex, don't have sex, because they will get people pregnant or get pregnant. And I've had parents take their daughters to get birth control because they don't trust that they won't be vulnerable. And it's really important to know that women with special needs, boys too, but I think women at a higher level, as teenagers to adulthood have a 70% chance, there's 70% of them, I guess 70% of them have been sexually assaulted. Huge numbers. And so these girls who are uninhibited, who just want to fit in and all that, it's important to protect them from that. So we are actually working on, I don't know if I put that slide in here. I think I did. I have we're working on transition toolkit for FASD to adulthood. Research does show there are poor outcomes later in life. Mental health problems are one of the big ones. Over 90% of these kids grow up with a mental health disorder. And a lot of that is due to their early life trauma and the depression, anxiety, ADHD becoming causing a lot of the more mental health things, or they've inherited it. But school, you can just see all the labels down here, trouble with the law school issues, and living independently. Those right two columns are so important for an adult to be able to live independently if they can, and to have a job, to be able to have a living wage. It's the rates of it's 80% of these people can't do that. So some of them end up on disability, Social Security. I really encourage parents, and a lot of my patients are growing up now. So I encourage parents to become their power of attorney. If their IQ is low, they can become guardian for them. But you can also do a little lower level of that called power of attorney. So you can help them with their finances and help them with medical care. A lot of these kids grow up wanting the 16-year-old I told you about. He said, I can't wait till I'm 18 and I can get out of the house. And he's not a bad kid. He is not like hurting people. He's just is tired of his parents telling him what to do. And he doesn't understand that he actually has to have a job to be able to afford an apartment, to be able to live independently. And so it's going to be really hard. And his parents are very fearful that he's going to end up institutionalized in the judicial system. And I'm trying to calm them down right now. Like, marijuana does not set you there. It's, we have to figure out how we can help him understand that he needs help. So when he's 18, he doesn't just run and, end up living in someone's basement. So here's the toolkit we're putting together now. It's not been published yet, but we are getting close. I think it's going to be put on the AAP website. And there's just to help guide parents through all these things. So I'm not going to go through everything, but it's a cool thing. I kind of talked about this already. The DSM-5 is for general psychologists, neuropsychologists, pediatricians. People can use this to give this diagnosis. You don't need a specialist. to do it. If you have a complicated kiddo, I would still call on the step specialist to give this to kind of go through all the things for this diagnosis. But what's nice is just to let you know about our team, and then I'm going to tell you what the AAP has on their website for pediatricians. So in our visit, we actually do this pre-visit where Jennifer will contact the patient and get all the information that helps us make the diagnosis. And that includes things like growth charts from their life. How many growth charts can we get? So that we know, because we can take a low height and weight even at birth. If they're small at birth, we can count that toward fetal alcohol. Physical findings. And then during the visit, I will do the medical part of evaluation, which is like, it covers everything. We still got, it's not just a physical exam and I measure the eyes, I do all that, but I also do a comprehensive developmental behavioral evaluation. How are they eating and how are they sleeping and how is school going and all that. And then we give feedback. We do a feedback visit a week or two later after Dr. Tangent can score everything. We put it all together and we give them it's an hour-long feedback. We give a lot of talking about describing that child so they can go away understanding their child better and then recommendations. And then our social worker will follow up if a parent needs resources and things. Just so you guys know, like this is the scoring system that I use, which is more detailed and we wouldn't expect pediatricians to use this, but it's a nice system and it's used for research. The University of Washington put this out. It's called the 4-digit code and it scores these 4 criteria on a scale of 1 to 4, and which gives you 256 different options, which makes it sound very overwhelming, but it's really not. Like I said, exposure or not, and then deciding the level. We're actually talking about now considering making this levels of FASD rather than all these different diagnoses, which like autism, they've come up with level 1, 2, and 3 now, which helps you understand the level of severity. Oh, I put in, so it might look like this. A lot of times, some risk means we got confirmation they drank at least once during pregnancy, or it could mean they drank a lot. Any risk in there. A lot of times we have to put unknown. And then if in that case, if a mother says, no, I did not drink, I just used drugs, I will put, and the adoption parent says, yeah, but they've been in alcohol rehab several times. Sometimes I will put some risk and sometimes I'll put unknown, but I highly suspect it, and you should still learn all about it and see your child from that perspective. High risk is if you have blood alcohol levels from a mom, or a mom says, oh yeah, I drank most of my pregnancy. Okay. This is what the facial features can look like. This is looks like an AI generated drawing, but it's one you'll find online. There are other features besides those core 3 facial. So the eye size, the lip, and the philtrum are the 3 core features. And you have to tell me, I know we're reaching near the hour, how far I should go. I'm done with like the main stuff, but I can go through details of the
Okay, if we just took our remaining 5 minutes and just had some questions or
Yes.
discussion,
Yes.
this has been really great. Any one of us could encounter either an adult or, kids are sometimes running around the room. And even if we're not primarily taking care of that person, say, this looks like fetal alcohol syndrome, and to want to give some coaching or direction. But I wonder in our last minutes if there are questions or if we can have a little bit of discussion.
Yeah, for sure. Yeah, these were my extra slides, so I'm kind of done with that. I'm going to put this thing up if we had time to go through.
Our hour goes by so quickly.
I know it does. This is my summary slide. Okay.
Yeah, no.